Good evening. I'd like to thank the organizers for, on the behalf of our panelists, Dr.Umamaheswari, Dr. Ganesh, and Dr. Shivan, the opportunity given for us. I assure you, next 40 minutes will be a very interesting session, though it's a very tough topic to deal with. I am blessed with three panelists who are well experienced. Umamaheswari, basically a neonatologist, developed interest in development, developed interest in IEM, and now she is diagnosing, managing, spending a lot of time in children with IEM. She also improvised a lot of protocols which suits for Indian environment. And Dr. Ganesh is an academic pediatrician from Rainbow Children's Hospital. So I cannot introduce my panelists for a long time, so you have to project it. So Dr. Ganesh is an academic pediatrician from Rainbow Children's Hospital. So whenever we see a rare topic like gallstones or pancreatitis or PGs when they are given, the first, when we browse the article, Ganesh and Suresh's name will come. So he is the metabolic specialist working with children with IEM. And Dr. Shivan Kesavan is a pediatric neurologist from Mehta Children's Hospital. He is a combination of academic brilliance, friendliness, easy approachability. Most of his patients will have their numbers and uniformly liked by children, their parents, and also pediatricians. So with the strength of my panelists, we will enter into the topic for the next 40 minutes. Can I have a slide, sir? So when I was discussing with one of my friends from Karaikudi that I am going to have a panel discussion in this Saturday, he told me that this is a word he used. Ganesh, I just introduced, I take this time for discussion. Dr. Shivan Kesavan also I introduced, take this time for discussion, and Professor Umamaheswari. See, what are IEMs? No? Simple words, when we explain the parents, suddenly we put a word, even we don't understand IEM. So generally we used to explain it with the help of some pictures. See, you go to the kitchen, they brinjal, carrot, everything, they cut into pieces and they take the edible things and non-edible things. Separating the edible, non-edible things with the help of scissor and knife. Same thing is when we eat a food, it is converted into useful and useless things by the enzymes, set of enzymes, and the useless things are excreted, useful things are taken into the body. When there is a confusion in the failure of enzymes, all the useless things gets accumulated on the body, leads to a lot of problems. This is the way we generally explain to the parents. When you will suspect IEM, there is an unexplained disease. So the common etiological factors are infection, injury, intoxication, 3 I's. Always remember the 4th I, when there is a parental consanguinity, neonatal death, similar illness in the siblings and developmental delay. So what are the various categories? In a simple, now all of us are fond of food. So we are fond of carbohydrate food. So carbohydrate metabolic disorders, fatty acid disorders, protein, amino acidopathies, organic acidemias, urea cycle disorders, and lot of, don't forget about mitochondria, so mitochondria disorders. These are the categories. Analyzing IEM, something like 5 or 6 or 7 blind person, trying to identify the elephant. So he's a hospital pediatrician, community pediatrician, person in PICU and NICU, geneticist and biochemistry. Each one have their own approach towards IEM. How do they present clinically? Encephalopathy may be a DD for CNS infection. Effortless tachypnea may be a disease, DD for diabetic ketoacidosis, recurrent vomiting, cardiomyopathy and dysmorphism. The biochemical disturbance are metabolic acidosis, hyperammonemia and hypoglycemia and high lactate. When all the common things are excluded, as I said, injury, intoxication, infection, think about it as a 4th etiology, particularly there is a parental consanguinity. Actually, this is a child presented with fast breathing, saturation maintained, there is no adventitious sounds, no retractions, landed with the diagnosis of effortless tachypnea, blood sugar was done, DK was excluded, urea creatinine is normal, renal failure excluded, finally turned out to be inborn error metabolism, isovaleric acidemia. This is how the diagnosis of IEM goes, mainly by exclusion. First round question is, when I talked this to one of my pediatric colleagues, he said, I am seeing 100 patients and more than 100 patients in Karaikudi every day, including holidays. I don't come across any IEM in the last 5 or 10 years. Should we waste time on discussing about this rather than giving a topic like asthma or seizures or pneumonia? So I'm just putting the first question is a negative question to Professor Uma, who spends more time with children with IEM?
It's a very valid question. If anyone is asking, will I ever see, if a pediatrician is going to ask me, will I ever see IEM, I would say the answer is yes. Definitely, it is that like we are maybe like a tip of iceberg. It is not being identified. Only when the severe symptoms happens and once they reach the tertiary care center where evaluation, diagnostic evaluation could be done, maybe like we are diagnosing it. So there are lots of more IEMs like where it is hidden at the community level and it goes undiagnosed both for the family as well as for the individual child. So there are many misconceptions regarding IEM. So they might think that it is a very rare condition, etc. So if I have to tell about the spectrum of IEM seen in our clinics. Next slide. So this is a 3-year data which we presented as poster. Whatever we read in Nelson, like MSUD, PKU, homocystinuria, MMA, IVA, all these patients we are seeing in clinic. That is because of the diagnostic evaluation and an awareness or like thinking about IEM. So that is the first step as such. So if to kind of demystify the misconceptions which they have, if they think that the IEM is rare, maybe individually they are rare. Like if I take individual conditions like PKU or OTC deficiency, they might be rare, but collectively they might be more common. So we have to take IEM as a collective aspect, then it is common. And also they think like only when there is a positive family history we need to consider IEM. It is not so, because majority of them are autosomal recessive where the parents are carriers and they do not have any signs and symptoms. And also like it is a great mimicker, like how we are saying sepsis is a great mimicker, even IEM is a mimicker. Sir, as you have told, sir, the previous case, we could think of DKA also, the deep acidotic breathing. So IEM is also a mimics, it mimics sepsis, it mimics other encephalopathy, and also sepsis can also coexist with IEM. So, and also one might think that, oh, this IEM is complex, I need to kind of remember so many steps in biochemical pathway. I would say clinicians do not have to remember any steps as such, they have to only have an algorithmic approach. And also what is the use of knowing? I would say many IEMs are treatable. If there is an intellectual disability with a single gene disorder like which is not treatable, or IEM, which one I would prefer? I would prefer IEM because many are treatable. Say for example like biotin biotinidase, and I can say many examples. And also for genetic counseling, and when we have to say like what we should tell the parents in terms of counseling and what is the recurrence risk. For these things, we need to be aware of IEM and we should have an open mind.
So you mean to say that what brain does not know or eyes will not see? Because we don't think about it, that's why we miss probably. Once we think about it, probably we will also try to find out more IEMs, possible way. Now, another sincere pediatrician from Tindivanam, he said, really I want to make a diagnosis of IEM. But I am seeing 150 patients per day. I can spend hardly 2 minutes. Can you tell some points so that we can identify some clues? Just looking at a child. I don't even have a time to remove the shirt, auscultate. Just to looking at the child. So tell me some few points by which I can suspect IEM. I can refer. I cannot do anything there. That's what his question. What, Dr. Shivan, what you are going to?
So thank you for the
Shivan
question.
is a very busy child neurologist.
So this is one of the FAQs for any practicing pediatrician or a postgraduate. So the answer is simple. Whenever something doesn't fit into a known cause for developmental delay.
Like Avayar asked, no, Ana, Avanna, Avanna, Mari, Varisipadra Mari, he has arranged it in alphabetical order to ABC.
So yes, so you can remember it with the initial few alphabets like A, B, C, D. But when you approach a child, you always ask for history. So when you have consanguinity in the family, you have history of sibling deaths, you have unexplained deaths in the family, because many disorders are autosomal recessive. So you won't have the parents to be symptomatic, but you can have affected members in the family. And you ask for history of developmental delay with drug refractory seizures, particularly in infancy, developmental delay without an established perinatal cause. Episodic decompensation or regression always should make you, stand on your toes for looking for a cause other than, the so-called cause for CP, that is perinatal brain injury. When you have certain facial features, or when you have certain neurocutaneous markers, or when you have certain skin or hair or eye signs which are suggestive of specific IEMs, then you always have to think about them. Head circumference, you know that in most of children developmental delay, we have a normal or a smaller head circumference. Whenever you have a large head circumference or macrocephaly, you think of many of the inborn errors of metabolism. You look for history of movement disorders, you look for history of very problematic behaviors, especially falling under the spectrum of the autism spectrum disorder, not in isolation, but occurring with all the other things which I have enlisted here. You look for organomegaly, you look for systemic signs and symptoms, as mentioned in the slides previously as well, for hepatomegaly, splenomegaly, and signs of cardiac dysfunction. All these individually may not hold good or be a good handle for diagnosing IEMs, but when you see them as a group, when you take 2 or 3 together and you find that in one patient, that is actually very helpful and gives a higher yield for a diagnosis of IEM. Most important of this list is the history of a very smooth perinatal transition. You find the child to be term, you find the perinatal history to be very uneventful, you have no NICU stay, and then the child still has developmental delay with or without either of these features. Always think of an inborn error of metabolism, because as ma'am has said, many of them are eminently treatable and most of them are preventable in the next offspring. Thank you.
Thank you very much. It looks like as if what Shivan told, it looks like simple one. We can even type and keep it in front of my table desk and then probably look for these things. This is a question for Dr. Ganesh. When you are working on children with general cases, problem cases, in any time you will find surprise that you are landing upon a child with IEM. If so, can you just, suddenly you might, when you're investigating or when you are examining, you would come with an idea of whether it could be a possibility IEM, which would have made your eyebrows to raise. So can you narrate some case scenarios based on that?
Generally, it's a myth that most of the children with inborn errors of metabolism present in an acute metabolic crisis, they land up in PICU, and we don't often see in our office practice. But it is the factors that all of us would have seen at least one IEM a week in our office practice. To narrate this is a 13-month-old child who was second born to non-consanguineous parents with smooth perinatal history, and his elder sister is normal. This child presented mainly for growth, not able to walk and not able to sit without support, and there was no history of seizures. He has been evaluated elsewhere for the same with MRI brain, including MR and spine, that was absolutely normal. On examination, he has had microcephaly, hypertonia, exaggerated deep tendon reflexes with the upgoing plantars. Otherwise, there were no neurocutaneous markers in this boy. Next slide, please.
Look at the word, no, unemergent antenatal period, smooth progression. So definitely it is not due to perinatal insult.
Yes. So we did just liver enzymes as a part of workup. So where there were raised serum transaminases and his ammonia was 92 micromoles per liter. So any ammonia more than 50 micromole per liter beyond the newborn period is always abnormal. We have to evaluate. Plus hyperammonemia, elevated liver enzymes may give a clue to the diagnosis of an underlying inborn error of metabolism, where in this child it may be a possibility of a urea cycle disorder, or it could be a fatty acid oxidation disorder. We did the plasma amino acid profile, which showed elevated arginine levels as seen in the slide, confirming the diagnosis of an arginemia, and a molecular genetic testing showed a pathogenic mutation confirming the diagnosis of an arginemia. So he was started on sodium benzoate and carnitine, and he was advised a protein restricted diet, and at 18 months follow-up he is able to sit without support. So far he has never had any seizures, and now his speech development is also normal. So this is a case scenario which illustrates that IEM can be seen in our office practice also, narrating the importance of correlating the clinical history, our examination findings, and having a diagnosis of IEM in the back of our mind whenever we are evaluating a child of a similar disorder.
So, a child with a normal antenatal period, perinatal period, presenting development delay, and unusual liver disease unusual in this age group. So, based on that, IEM was suspected and it was proved. Thank you, Ganesh. So, I just have a question for the audience. How many of you have written the birth chart or horoscope, ஜாதகம் எத்தனை பேர் ஜாதகம் எழுதி உங்கள் பிள்ளைங்களுக்கு கை தூக்குங்க உங்கள் பிள்ளைங்களுக்கு கொஞ்சம் பேர் தான் இருக்காங்க யாரும் நிறைய ஜோஷியர் இல்லையா ஓகே how many of you ordered for neonatal screening almost equal number no neonatal screening is definitely cheaper than நிறைய ஜோஷியர்லாம் 10,000 வாங்குவாங்கன்னு சொல்லுவாங்க so neonatal screening not that much costly Uma neonatal screening how much it costs
Sir, it varies. If
ஒரு பாப்புலர் ஜோஷியர் விட கம்மியா தான் வாங்குவாங்கல்ல
universal screening I think it will not be that costly. It is less costly than what they spend for either a baby shower festival or like naming ceremony. It is definitely almost like 1/10 or 1/50 the cost of
definitely
things which
that's what she was telling வளைகாப்பு பண்றதை விட first birthday celebrate பண்றதை விட cheaper தான் இருக்கும் definitely. So can you tell Dr. Uma, you are the right person to tell about neonatal screening, what is the cost benefit ratio? Is it available in small towns like Tenkasi, Nagarkoil or Nagapattinam? Can you enlighten a case scenario based on by newborn screening, how you identified a problem and how made a positive impact on the family?
Definitely I would say that newborn screening it is a good program which has been nationwide program which has been introduced in many developed countries. If you see here it is Dr. Guthrie observing in 1963 a nurse doing a filter paper card test for phenylketonuria. Even like he says no child should die or suffer disabilities if a simple blood spot can prevent it. But like even this is a child whom I am seeing in the clinic 50 years, exactly 50 years after that 1963 where the child presents with microcephaly and the features suggestive of phenylketonuria. So definitely a preventable disorder because we have not screened the child has landed up with developmental delay, microcephaly and behavioral issues. The screening should be taken forward in terms of, I would like to quote it as with an example. So this is a term baby uneventful antenatal period, like was born in our hospital. So the newborn screening was done. So we tell it as panel 1 and panel 2. Panel 1 is for thyroid and congenital adrenal hyperplasia, so 17 OHP. And panel 2 is for biotinidase, galactosemia and TMS, which encompasses of 21 disorders. So in that like biotinidase came as positive. So it is by just a simple filter paper card test. So we have to follow very meticulous process of doing a filter paper card test. But as you say, it can be transported from Tenkasi or Nagarkoil or any district to the place or the lab where it is being done. Actually like we
do you get all the dry blood smears are in a proper technique or are there whenever somebody takes these DBS from outside in small hospitals and villages and small towns, do you get a correct sampling or will not be a proper sampling?
Sometimes it can be a overlay sample or like it can be a smudging. But with simple education, I think our healthcare worker would be able to do, our lab people are trained to do a filter paper card. It is just by simple pricking and the blood should be made to flow on the filter paper card and it should be air dried by stocking it and then put it in like something like a butter paper cover and then sent by post with information filled in. That is because for many pre-analytical factors are influencing the newborn screening. So we want as much information, say for example blood transfusion given, it's one of the twins. So such informations are needed during analysis for pre-analytical factors, but it can be transported from any place to any place. So to complete that particular story which I was telling, so we got the biotinidase enzyme as low in the screening test and we confirmed with the serum biotinidase assay which also showed a very low level and baby was started on oral biotin. And so 10 milligram once a day, very simple tablet available all the places. So it prevents all the late effects of biotinidase deficiency in terms of like no skin rash or alopecia. These are prevented by starting early on in newborn screening itself. And this baby is doing well and developmentally normal. So, if I have to share the screening data of ours, this is again one of the screening data present, 4-year data presented. We started extended newborn screening in September 2016. So this is a 4-year data when we screened 8,940 babies total. The total screen positive was 9, out of which 6 were biotin-based. So in this place, biotin-based is prevailing, followed by VL-CAD and MCAD. So total 9 babies we got positive with the detection rate of 1 in 993. It is coming almost equal to that of congenital hypothyroidism. So, we are continuing the screening program. We have added on more patients right now, but definitely biotin-based is something which is prevailing, followed by fatty acid oxidation defects, sir. Yes.
Thank you, Ma. Dr. Shivan, you told me the list of conditions, where that list of clinical signs which can be easily identified. Was it useful for you?
Yes,
can
sir.
Can you show some case reviews where you are able to identify with the clues you are given to the audience?
Yes, sir. So I'd like to present 2 illustrative cases in a very short manner to just say that physical examination helps in identification of 2 potentially treatable inborn errors of metabolism. So this was a 2-year-old boy who was labeled autism spectrum disorder, who presented with speech delay and behavioral problems. Again, he had a smooth perinatal transition, nothing in the family history to raise red flags such as consanguinity and a negative family history. He had microcephaly. Generally, we say that children with the ASD spectrum have a normal or a largish head circumference, but he had microcephaly. But rest of his examination, systemic and neurological, was unremarkable, and his MRI done from outside was normal. What this child would be passed off as a normal
can you
child.
ask the audience when they,
Could you find anything abnormal
anything
in
you
this child?
identify?
Quickly, can anyone just shout out? Do you find anything abnormal in this child? This child is a North Indian child. I deliberately haven't shown the parents because there is something in this child which is not seen in the parents. Yes, perfect. Next slide, sir.
Thank you.
So the hair is lightly pigmented, which was, very odd for the ethnicity from which the child had come from. So this lightly pigmented hair made us think of a disorder which we finally diagnosed with a tandem mass spectrometry of the blood. So this is classic phenylketonuria. Children present usually in their early childhood, not even in infancy. They are normal at birth, ultimately develop developmental delay. They are hyperactive with very stereotypic movements, lots of behavioral problems falling into the autism spectrum. They have a very light skin complexion. The skin complexion may or may not be light, but the hair is light in most of children. The urine and sweat has a mousy or musty odor, but we don't depend on that for diagnosis. A very small minority, 1/4 may have seizures, most have developmental delay, some may have motor signs, and most of them have a small head or a microcephaly. Next slide, sir. So this is diagnosed by plasma amino acid analysis by tandem mass spectrometry. It shows that phenylalanine is massively elevated, and of course you have the other metabolites which are found downstream, which is diagnosed with the urine organic acid study in the using GCMS. Next slide, sir. So the second case is a 4-month-old boy who was the first child, again non-consanguineous parents, smooth transition perinatally, seizures since 1 month, repetitive myoclonic jerks. Development is poor, no head control, no social smile, no cooing, hypotonia with brisk reflexes. Family history is negative. The basic metabolic workup, which we will be detailing a little further, was all normal. MRI brain shows a very non-specific white matter changes, which was disregarded. EEG shows stark burst suppression. This is what was found in the general examination. You can see alopecia in the scalp, you can see a patch of cradle cap or persistent seborrheic dermatitis, you can see flexural rash, and these are characteristic of the disorder which ma'am had recently earlier pointed out, biotinidase deficiency. So this can be a clinical spotter for a diagnosis. When diagnosed very early, these children can be prevented from having devastating neurological outcomes. Next slide, sir. So the biotinidase levels are diagnostic, which are low in these children, and biotinidase deficiency should be considered, and a therapeutic trial of biotin should be tried in all infants until 1 year of age, I would say, with refractory seizures and developmental delay, until you negate the diagnosis or have an alternative competing diagnosis. So these were the two cases which helped, where a clinical examination helped in a diagnosis of a treatable inborn error. Thank you.
Thank you, Shivan. We started the test match. I think we are running short of time, maybe only 20 overs match we have to play, I think. We have to be a little faster. And Dr. Ganesh, can you enlist some few cost-effective management in IEMs?
So it's like diagnosing IEM is going to be expensive. Treatment for IEM is going to expensive. Again, there are myths about it, but there are few cost-effective manageable IEMs what we can see in our day-to-day practice. One such example is as what Dr. Uma and Dr. Shivan has said, biotinidase deficiency. Biotin tablets are pretty not that expensive. If you start early, then that improves the outcome of the child. Similarly, the child with the congenital sucrose isomaltase deficiency, where there are special formulas, this baker's yeast, what is normally available for in our routine cooking purposes, that has shown to supplement this isomaltase and maltase, so that has shown to reduce the duration of diarrhea as well as the frequent admissions of these patients. Third is the HMG-CoA lyase deficiency, a simple intervention, avoidance of prolonged fasting. So the simple maneuver which helps to improve the outcome of these children, especially HMG-CoA lyase deficiency, and even children with medium chain acyl-CoA dehydrated deficiency and fatty acid oxidation disorders, this improves the overall outcome of these children. Similarly, a child with a cerebrotendinous xanthomatosis, usually they present in the newborn period as a neonatal cholestasis syndrome, and eventually once they are about 10-15 years of age, they do develop xanthomas as well as they do develop ataxias. So if you are able to diagnose these children in the newborn period and offer them a cholic acid, then that again improves the neurological outcome of these children. Menkes disease, copper histidine, especially if you start the treatment protocol in the newborn period, again that improves the quality of life of these children. And the most important, say, creatine kinase deficiency. Normally children with autism having a seizures, or male children coming with a developmental delay, where you suspect a creatine kinase deficiency, MR spectroscopy picks up the diagnosis, starting up a creatine monohydrate powder that is going to improve the neurological outcome of these children. So these are certain examples of low cost interventions where we diagnose early and start, that improves the overall outcome in these children.
Thank you, Ganesh. Dr. Uma, you said both you and neurologist together investigate and managed a child who had a treatable problem. Can you enlighten on it? I think we'll have to go a little faster, I think, maybe 1 or 2 minutes. We have only 13 or 14 minutes. I can borrow 10 minutes from the...
Next slide, sir. So you can play the video. So you can see this child is diagnosed as cerebral palsy. So as Dr. Shivan was telling, that movement disorder is something like where we should suspect IEM. Next slide, sir. So we did a basic TMS which showed a phenylalanine elevated. It was not as elevated as that of a classical phenylketonuria, but however it was 677 was quite high. So we went ahead with neurotransmitter analysis of neopterin and biopterin in CSF. Next slide, sir. So if you see here, the neopterin level is very much elevated with a low biopterin, which indicates PTPS deficiency. So the treatment of choice would be sapropterin, but however, like we started on phenylalanine restricted diet for this baby, which has showed improvement, and also started on DOPA with the help of neurologist.
Thank you, Uma. This 6-month-old child was referred to you with development delay in liver disease. What are the differential diagnoses, Ganesh?
As it has been reiterated earlier, we have to have the prototype matching as well as the algorithmic approach. It's like this in our undergraduate days and postgraduate days. Abdomen case, what are the diagnoses of hepatomegaly with splenomegaly with hepatosplenomegaly with fever, hepatosplenomegaly with jaundice. So similarly, the inborn errors of metabolism which can have hepatopathies, predominantly the liver involvement. One is the urea cycle disorder, because all of us know the urea cycle operates in the liver. Second thing is the fatty acid oxidation disorders, where they have hypoglycemia, then elevated liver enzymes, they do not have any ketones in the urine, right? Storage disorders, glycogen storage disorders, galactosemia, etc. They can have inborn errors of metabolism with hepatomegaly. Mitochondrial disorders, mitochondria affects any part of the body, predominantly the liver, heart, skeletal muscle, brain, right? Carbohydrate metabolism does amino acidopathies, sometimes tyrosinemias, which can present as acute liver cell failure in the newborn period, right? And disorders of bile acid metabolism like progressive familial intrahepatic cholestasis syndromes, etc. Peroxisomal disorders, hepatorenal-ocular syndromes, all those things. These are some of the inborn errors of metabolism where they can have a liver involvement.
Thank you, Ganesh. Like to know that so many conditions are still there in IEM presenting with hepatic impairment. Over to Dr. Ganesh. Shivan, do you think IEM is considered a possibility even for a school-going child? No, generally we think only in infant, toddlers only. The school-going child also, do you think the possibility of IEM? Can you share any clinical experience based on this?
Yes, sir. So this should be considered as a possibility, but you must also be aware when answering this question that there are certain inborn errors which have subtle signs in infancy or early toddlerhood which are lately recognized in school age. So that is one thing. But there are certain disorders which can present truly in the school age, that is somewhere around 5 years of age and more later than that. So among them, I would like to highlight uricycle disorders which can present with intermittent or episodic ataxia, dopa-responsive dystonia which can be misdiagnosed as cerebral palsy, clumsy gait, and they generally present with frequent falls before coming with a diurnal variation before coming to the neurologist. Homocystinuria, presence with thrombosis, it can present at any age after a triggering illness like a fever or infection or dehydration with cerebral synovenous thrombosis. Wilson disease, as you all know, neuro-Wilson presence beyond 5 years of age with psychiatric symptoms, movement disorders, dysarthria and drooling. Biotinase deficiency has a very variable spectrum in age of presentation. They can present even in adulthood with spastic paraparesis, vision loss, intermittent ataxia, mimicking a lot of acquired disorders. And as you all know, adrenoleukodystrophy presents in the school age between 5 and 10 years of age with psychiatric symptoms, poor scholastic performance and seizures before having the classic white matter long tract signs. This is an illustrative case. It's a 5-year-old girl presented with a 2-day history of irritability and seizures on day 3 with lethargy, vomiting. There was no fever, but there was a vague history of trivial trauma 3 days back. She was second born to again consanguineous parents, which is a red flag, had hyperactivity since infancy, which was largely ignored, but the development was normal. Examination was unremarkable, but because of the synovenous thrombosis which was shown in the MRI, she had papilledema. Her elder sibling had poor school performance, had myopia, she was not evaluated. So this child turned out to be, next slide, sir.
Can I say that a sagittal vein thrombosis in the absence of nephrotic syndrome, yes, or in the absence of diarrhea, probably I think about a rare condition like IEM?
Yes, sir, exactly. So this child turned out to have classic homocystinuria. You can see that the plasma homocysteine levels are high. The elder sibling also had high plasma homocysteine levels. The younger sibling doesn't have the very classic facial features, but the elder one does have a very tall, slender physique with a very elongated face and a broad forehead, inverted triangle kind of a face. So this, as you know, where the fault in the metabolic pathway is, it leads to increased viscosity of the blood leading to thrombosis and lot of other systemic manifestations. This was an example of a patient with an inborn error presenting truly in the school age, which brought this disease to attention.
Thank you, Shivan. A 10-year-old boy has been brought for new onset of behavioral problems. So the mother accuses that all the time he's handling only phone. So there is a problem. So his marks are coming down. What are your thoughts as you are managing this similar issue with a lot of commitments? Do you think his phone is the reason or any other reason is there?
So in this age, phone is, the gadget addiction is an important reason, but you always have to have the eye for diagnosing organic disorders and psychiatric disorders which can come with this presentation. So among the inherited metabolic disorders such as IEMs, Wilson disease and, as I told you in the previous slide, adrenoleukodystrophy has a true presentation in the school age. Somewhere between 5 and 10 or 12 years of age, they can have the first clinical sign which brings the child to the hospital. The acquired causes include subacute sclerosing panencephalitis. It is a slow virus disease due to a previously inoculated measles virus into the brain. It is called SSPE. And you have acquired causes, the common ones in the northern part of the country being vitamin B12 deficiency and chronic lead intoxication in the right clinical setting. And of course, you can have true psychiatric disorders which have a trigger and onset in the school age. Major depressive disorder or bipolar disorder. So beyond the very benign causes such as mobile phone addiction and all that, you should always think of organic causes. So there is an illustrative case in the form of a 9-year-old boy who had a very normal birth and development. Family history was negative with a very typical presentation of a 6-month history of poor scholastic performance and behavioral changes. He would not respond to auditory cues. Auditory inattention was the problem which brought him to the hospital. He is a boy and he has symptoms after 5 years of age is what you have to note. He had brisk deep tendon reflexes in the lower limbs, pale optic discs bilaterally, and this is a picture which shows hyperpigmentation throughout his hands and forearms. So this helped us make a diagnosis of adrenoleukodystrophy. So this MRI on the left is a T2 sequence which shows demyelination in the posterior part of the brain. This is very classic, and this is one inborn error of metabolism. Whenever you put contrast into the veins and it lights up in the brain, you think of an infection, you think of a tumor, but this is an inborn error of metabolism which has contrast enhancement. So this is called the Garland sign, or this is the ends of active demyelination. Because there is inflammation, it enhances very smoothly and shows on the T1 contrast image on the right. So this is adrenoleukodystrophy. Next slide, sir. Which presents as X-linked disorder. It is seen in boys. It presents after 5 years of age. There are 3 forms, among which the childhood cerebral form is the most common form. They can present with subclinical adrenal involvement, but rarely they can have only, they can present to the endocrinologist with only hormonal problems. Later on, they can also present in adults. So elevated very long chain fatty acids in the blood helps in diagnosing this, but it is confirmed by a genetic study. MRI, as I had already showed you, showed parieto-occipital white matter changes with contrast enhancement, which is typical. Treatment is supportive, but as I'll be explaining in further later slides, in the pre-symptomatic or very early symptomatic stage, if you can catch hold of these patients, you can do a hematopoietic stem cell transplantation to prevent progression. Thanks.
Thank you, Shivan. 6 months old infant referred to as having acute ectopic viral hepatitis. Referral pediatrics is confused because they did not find any viral markers found to be positive. Child also has a developmental delay. How will you approach this child?
So this is a child who presented to us at 6 months of age, firstborn non-consanguineous parents. Well, till a month ago, presented with not gaining weight for a month, poor feeding and lethargy for 2 weeks, and history of vomiting. She was taken to her regular pediatrician who had done an ammonia, found to have raised ammonia levels, elevated liver enzymes, and was referred to us for further care. Next slide, please. On examination, she has not had any head control. Developmental age corresponded to only 3 months of age. And then on examination, this baby was irritable. Abdominal examination was normal, and CNS showed hypotonia with preserved reflexes. Next slide, please. So the investigations, this child having elevated serum transaminase levels, hyperammonemia, coagulopathy. Her PT and PTT were prolonged. She had metabolic alkalosis, and total counts were increased with normal lactate glucose, and there was no ketonuria. So the differential diagnosis, what we thought of urea cycle disorder because of elevated liver enzymes and alkalosis, organic acidemias, yes, because of hyperammonemia, tyrosinemia because of PT and PTT did not correct with initial vitamin K and FFP, and other liver dysfunction secondary to any other infection. So she was started on the hepatoprotective measures, and for hyperammonemia she was started on sodium benzoate along with arginine. Further investigations revealed her amino acid profile was normal, cell carnitine was normal, urine for succinyl acetone was normal, ruling out the tyrosinemia, but urine GCMS showed a elevated orotic acid level, confirming the diagnosis of a OTC deficiency. Next slide. And subsequently the genetic testing showed heterozygous mutation in the OTC gene, and with the above treatment her ammonia levels dropped, and LFT started showing a normalizing trend with improvement in the normal sensorum. Now at 2 years of age she comes to the OPD, her development is absolutely normal, and now she has got her younger sister.
Thank you. By stepwise approach, you are able to reach the diagnosis of OTC deficiency. And sometimes when we order the investigation, it is incomplete. So sometimes we miss a major diagnosis. Do you have any experience in this regard?
Sir, we happen to see a 12-year-old child, so who presented with intellectual disability, behavioral issues, and speech delay. Firstborn of third degree consanguineous. Father passed away, so mother is a single parent taking care of the baby. Had multiple hospital visits. They had MRI done elsewhere, showed some cerebral atrophy, but MRS was not done. So we did a TMS, GCMS, it was normal, and we did a creatine and GAA levels. so which showed a elevated GAA and which was consistent with a diagnosis of GAMP with a low creatinine. So this particular condition could have been very well picked up if the initial, along with initial MRI, if MRS also had been ordered. So the typical Hunter triad of creatine, choline and NAA was missing in this child. So the creatine peak is typically absent. So whenever we are evaluating for an intellectual disability, I think we should consider MRI along with MRS. However, like we had a biochemical testing because of the clinical suspicion, and also the genetics was showing creatine deficiency. We confirmed with reverse phenotyping as such for this child and started on creatine ornithine. So the child has shown some improvement. Maybe for earlier treatment, it might have improved the condition.
So MRI has to be done only with the MRS also, because that will give a clue for many of the IEMs.
Yes, sir. So every evaluation should include not only MRI but also MRS.
Thank you, thank you. This is for the audience. This is called a magical triangle of Ramanujan. I may need 10 more minutes. This is, whatever the way you add up, it will come to 139. The first 22/12/1887 is the birthday of Ramanujan. Very complex puzzle, but very interesting. Professor Uma, you also generally explain the diagnosis and management of IEM with very complex equation, but you can also make it simple and interesting.
Definitely, this is one of my favorite slides where we can work out in any IEM if you take, you can work out on decreasing the substrate or increasing the toxic disposal of toxic metabolites or providing deficient metabolites or increasing enzyme activity. So decreasing substrate is by, like if it is a protein disorder, we have to provide devoid of protein. If it is a lipid disorder, low lipid diet. And if it is a carbohydrate, we might have to cut down on carbohydrate. So if in PKU, it is low protein diet where breast milk will be the good source during infancy, later on followed by vegetarian diet, and also special formula deprived of PA. So the combination of these two decreases substrate. Increasing toxic metabolites may not be applicable in PKU, but maybe the presentations where metabolic crisis is there, we might have to decrease toxic metabolites in initial stages by dialysis, later on by maybe carnitine in organic acidemia. So providing deficient metabolite is to identify which metabolite. Let's say for example here in PKU formula is rich in tyrosine, so it automatically provides deficient metabolite. Increasing enzyme activity, if it is a storage disorder like lysosomal storage disorder, we have enzyme replacement available as such, but for small molecule disease, either a bone marrow transplant or a liver transplant provides a deficient enzyme. So here in PKU it will be sapropterin or biopterin, but it is not available in India, but it can be exported.
Thank you. I think we can skip few rounds and can we go back? Okay. This also we can pass it very fast. And this round constant evaluation. Ganesh, can you mention the common labs stepwise? Only 1 minute you can take.
So the labs in IEMS, basically first is the complete history and performing a thorough physical examination. 2, like how a CBC is mandatory for anybody who practices the medicine. It is for the metabolic specialist, it is always the GALAC. So glucose, ammonia, lactate, bicarbonate and ketones. So these 5 things forms the basis of our approach to IEM. Next, I hope this will be available in almost all parts of the country. Second thing will be the ordering for the amino acids, acyl carnitine, urine for organic acids. The third level is ordering the enzyme assays and the molecular genetic testing.
I think you explained this level 1, level 2, level 3. This is a sample collection.
This slide shows the sample collection, what tubes we have to normally take samples.
You can spend some time on this GALAC common.
So with the GALAC, I think most of the IEMs can be easily diagnosed. So in the first column, the glucose is low. There is an acidosis with increased lactate, ammonia and urine for ketones are positives. It fits into the diagnosis of an organic acidemia. So there should be a metabolic acidosis. There should not be ketones in the urine. So these two are the organic acidemias like your methylmalonic acidemia, propionic acidemia, isovaleric acidemia. The column 2, where the glucose is normal lactate is normal, but there is high ammonia levels and there are no ketones in the urine. Usually they'll have a respiratory alkalosis. So hyperammonemia with respiratory alkalosis is a urea cycle disorder. The column 3, glucose is low. There may be acidosis or there may not be acidosis with a slightly elevated ammonia and lactate, and there are no ketones in the urine. It fits into the diagnosis of a fatty acid oxidation disorder. The fourth will be the glucose is low, the ABG is normal, or there is an acidosis with high lactate levels, and there may not be ketones in the urine, which fits into a pyruvate DN deficiency or pyruvate carboxylase deficiencies.
Now, I request Dr. Shivan. Neuroimaging is an important part in the evaluation of IEMs. Can you explain a few things based on
So I'll just show some pictures. So I have this. I'll just show some pictures. This is just for your visual memory, just for the delight of viewing. So this is a classic MRI in Wilson's disease. You can see the bilateral basal ganglia changes and the thalamus changes. So this is classic in Wilson. Next slide, sir. Wilson disease has a name design which will be interesting for postgraduates. Next, sir. Next slide. This is the face of the giant panda sign. You can see the midbrain is involved, and you can see the area around the red nucleus looks like this. So this is the face of the giant panda sign which is seen in Wilson's disease. Next slide, sir. Another image to remember, this is glutaric aciduria. You can see that this is a bat wing sign. This is called the Sylvian fissure, which is widened. The anterior part of the brain is more atrophic than the posterior part. So this looks like a bat wing sign. And of course, you can see the basal ganglia changes here as well. This is classic in glutaric aciduria type 1. These children present with a large head. They are eminently treatable with a combination of carnitine and riboflavin. Next slide, sir. So this is an MRI which with a history of perinatal asphyxia and hypoxic ischemic encephalopathy. This would be called multicystic encephalomalacia. But without that history, if the child presents with a lot of refractory newborn seizures, think of this diagnosis sulfate oxidase deficiency. The MRI will be reported by the radiologist as HIE related changes, but you should always look for this diagnosis. Ma'am had already stressed the importance of MRS. This is one disorder which is again very eminently diagnosed by the MR spectroscopy. This is called Kesavan disease. Children present with developmental delay and regression with a large head. You can see the white matter changes, but don't worry about this. What you have to take home is this tall NAA peak which is present in Kesavan's disease. This is diagnostic. Another disease in which the MRS is useful is the maple syrup urine disease. You can see the brightened basal ganglia and the brainstem and cerebellum. This can also be called the double swan sign, which looks like two swans kissing each other. And this again is the basal ganglia, the brainstem, which is involved very brightly. The MRS is very diagnostic. It shows a prominent peak, which is because of the branch chain alpha keto acids, which can again be picked up by the MRS. Another disease, next slide, sir, where the MRS is helpful is Leigh syndrome. You know there is a mitochondrial respiratory chain defect, and as you know, the basal ganglia is a very highly metabolically active region, including the thalamus. So this all brights up in the MRI. But what helps you in the diagnosis is the presence of this very highly elevated lactate peak. This is a negative peak which is seen here in the form of a W or a inverted M. So this is diagnostic of Leigh's disease or a mitochondrial disorder.
Dr. Uma, you can explain about TMS, GCMS in genetic studies.
So along with GALAC, we'll be asking for a diagnostic TMS, plasma amino acids, urine organic acids, plus or minus enzyme assay. Next slide, sir. So TMS gives us two profiles, amino acid profile and organic acidemia profile. So if you see so this is an amino acid profile, where it is the amino acid profile is normal. Next slide, sir. So this is an acyl carnitine profile. Acyl carnitine profile, if odd chains are elevated, it is suggestive of organic acidemia. If even chain is elevated, it is suggestive of FAOD. In this patient, for example, the odd chain of C3 is elevated, so which is suggestive of organic acidemia. It can be either propionic acidemia or methylmalonic acidemia. So also the ratios are important. Next slide. The ratios are important. Here all the C3 by C0, C3 by C2 and C3 by C16 are elevated, which again suggest either MME or propionic acidemia or methylmalonic acidemia. Next slides. So the urine GCMS showed a methylmalonic acid peak, which confirms the diagnosis of classical methylmalonic acidemia. Next, so whether we have to do a genetic, we have completed a biochemical testing, it is showing already methylmalonic acidemia, whether we have to do a genetic testing or not. For example, in this condition, we have to differentiate between classical methylmalonic acidemia and also cobalamin A and B deficiency. Even in classical, whether it is MUT0 or MUT minus has an implication in treatment, because if it is a MUT plus, the enzyme activity is present in minimal quantity, so the response to B12 injection will be more, whereas if it is B0, the B12 has to be given more frequently than needed because the enzyme activity is very, very less. So genetic evaluation also helps in the present baby itself, not only in prenatal diagnosis of next pregnancy.
I think on want of time we are going a little faster. Over the management rounds, Ruma, we can tell about dietary management, both indigenous modifications and various formulas.
So basically diet management, it depends on whether it is a protein disorder or a lipid disorder or carbohydrate disorder. The diet management is basically for protein and lipid disorders. If it is a protein disorder, we have like formula available like it is available manufactured from Bangalore Prestige Diet, but it has to be a mixture of both natural protein and synthetic protein. Synthetic protein would be from the formula, whereas the natural protein source will be breast milk. Next slide. So there is a CERN website, which is a Southeast Asian network for genetics. They have given nutritional management guidelines. If you go to the toolkits, so the toolkit has the nutritional guidelines for MSUD, PKU, propionic acidemia and VLCAT deficiency. Next slide. So we also can use some Excel sheet to calculate. Next slide, sir. So the Excel sheet helps in if we are putting a combination of breast milk and synthetic formula, if it is exceeding, if we are giving more breast milk, it can give us an alert. For example, here the leucine level should not exceed 100 milligram per kg per day, but it is exceeding, so it is giving us an alert. We can use something indigenous like this as well.
Drugs, can you quickly
drugs, it's commonly the sodium benzoate, arginine for urea cycle disorders, and there are citrulline sachets which are available, and the glycerol phosphates which is available for management of hyperammonemias, along with other things like creatine powders are available, special ornithine powders are available for management of children with IEM.
Thank you. Happy to know that so many dietary modification drugs are available. Shivan, anything else to be added
I
to this?
just mentioned in the previous slides that when you catch these children with X-linked ALD very early, because they present after 5 years of age, so because of a newborn screening which can detect very long chain fatty acids, or if you had a previous sibling with ALD and you have one more male child born and you catch them before they develop symptoms, based on MRI you can do severity scoring and then send them for bone marrow transplantation, which can be effective. So pre-symptomatic or very early symptomatic children with X-linked ALD in boys is treatable with hematopoietic stem cell transplantation. This is an exciting new advancement.
Thank you. We'll come to the last slide. All of you can just explain 30 seconds you can take till the final carry home message. Professor Uma.
Many times we see like when IEM is suspected or like during evaluation breast milk is stopped and it is stopped forever. So like the mother is told that like it is really dangerous to give breast milk and she also dries up. But I would say that breast milk is an important natural source protein and it should be continued in many conditions. Majority of the IEMs, they tolerate breast milk very well in quantified amount, unless it is absolutely contraindicated like infantile onset VLCAD or galactosemia. So that I would want to put it across as my take home.
So except in galactosemia, breastfeeding should be continued even during evaluation of IEM. Ganesh?
In children with developmental delay with normal perinatal history, do not entertain the diagnosis of CP. Always have IEM as one of the possibilities in your differential diagnosis, because early recognition and treatment of these disorders generally do improve the outcome.
Dr. Shivan?
So, in drug-resistant seizures in infancy, even beyond the newborn period, but especially in the newborn period, consider vitamin responsive epilepsy. So you know pyridoxine dependent epilepsy, and there are group of disorders in that family which is expanding now. You have biotinidase deficiency, you have folinic acid responsive seizures. So whenever infants present with developmental delay and refractory seizures, refractory to one or two anti-seizure medications, start them as a trial until someone makes a diagnosis. Don't wait for someone to give you a genetic report or a TMS or GCMS report confirming the diagnosis. Start them on folinic acid, pyridoxine, pyridoxal 5-phosphate if refractory, and biotin, and wait for the diagnosis to happen at its own pace, and this can be brain saving for many of these infants.
So this one is from an old movie released in 1964. It says that Vanathil Sandhira Mandala Vanathi Todalama Induru Kalam Ingi Dunde Indru Kudete Badilunde. After 60 years, now Chandrayaan landed in the moon. Question for audience, who is the project director for Chandrayaan? Veeramuthuvel. So, which was not at all, we thought it was not at all possible, that now it is possible. Similarly, after listening to the learned panelists, probably you can also think about picking up at least 1 or 2 IEM in the forthcoming your clinical examination. Thank you very much for your patient listening. Thanks Dakshani and Sridevi for lending 10 minutes for us. Thank you very much.
Thank you so much, sir. I thank the moderator and the panelists for the